Okay, picture this. The doors of the ER burst open, they're shouting, alarms are going off. It's what you might call controlled chaos. A major trauma patient has just arrived, and a team is swarming, moving with this incredible urgency where every single second literally counts. So in this explainer, we're going to pull back the curtain and break down exactly what's happening in those first critical minutes. We'll look at the system they use to turn that chaos into a life-saving checklist.
So, why is this so important? Well, look at this number, 20,000. That's the estimated number of major trauma cases just in England, every single year. Let that sink in. That's about 55 people a day whose lives are on the line. When you're dealing with that kind of scale, you can't just wing it. You need a standardized, evidence-based approach that works every single time. It's absolutely crucial.
All right, so here's our game plan. First, we're going to talk about the famous golden hour. Then we'll get into a really big recent shift in how things are done, this new X that comes before the A. After that, we'll walk through the classic ABCDE survey step by step. We'll also dig into how doctors hunt for those tricky hidden injuries. And finally, we'll see how this whole thing fits together into one powerful life-saving system.
So let's talk about the golden hour. You've probably heard that term. It's that critical first hour after a major injury. Now, the goal here isn't to figure out every little thing that's wrong, not at all. It's a race against the clock with one single-minded focus. Find and fix the things that are going to kill the patient right now. It's all about priorities in a very strict order.
And that brings us to a huge change in thinking. You see, for decades, literally decades, trauma care always began with A for airway. It was gospel. But, medicine learns and evolves, often from tough situations like military conflicts. And those hard-won lessons showed us something incredible. There's actually something that can kill a person even faster than a blocked airway.
And check this out. This really shows the whole story. On the left, you've got the old way. A, B, C, D, E. Airway first, always. But look at the new way. The whole thing has been reshuffled. There's a brand new letter at the top, an X, and it has jumped the queue ahead of everything else. That X stands for catastrophic hemorrhage, massive, life-ending bleeding.
And listen, this wasn't just some small suggestion or a minor tweak. No way. The American College of Surgeons, the people who literally write the book on this stuff, the Advanced Trauma Life Support Guidelines, they made this official. This change is backed by hard evidence, by data that proves stopping a massive bleed has to be priority number one, period.
So, what exactly is this X? It stands for catastrophic hemorrhage. We're talking about massive, life-threatening external bleeding. The analogy the pros use is perfect. Think of a house on fire. If there's a ruptured gas line feeding the flames, what do you do first? You don't grab a hose, right? You shut off the gas. That's the X. You have to stop the fuel leak before you can do anything else. Okay, so once that massive bleeding is under control, and only after that's done, the team can finally move on. Now they begin what's called the primary survey. This is that systematic head-to-toe check, a repeatable process to find the next thing that could kill the patient, and it follows that familiar ABCDE sequence. All right, first up is A for airway. It's a simple question. Can air get in and out? The team is checking to make sure the patient's airway is clear, that it's open and protected. And a really key part of this is they're doing it all while making sure the spine is kept perfectly still to prevent any further injury.
From A, we go right to B, breathing. I mean, an open airway is great, but it's not much use if the lungs aren't actually working, right? So here, the team is hunting for really serious chest injuries, things like attention pneumothorax. That's a nasty situation where a collapsed lung starts trapping air, and that pressure builds up and literally squeezes the heart. It's something you have to fix, like, now.
Okay, on to C for circulation. Now you might be thinking, didn't we just cover bleeding with X? Well, yes, but X was for the massive bleeding you can see. C is all about the bleeding you can't see, the internal stuff. Is the patient going into shock? Here's where they're looking closely at blood pressure, at heart rate, trying to figure out what's going on inside.
And they're not just guessing. They're looking for very specific red flags, almost like tripwires. European guidelines are super clear on this. Is the breathing rate too fast or too slow? Is the heart rate cranking above 120 beats a minute? Is that top blood pressure number, the systolic, dipping below 90? These aren't just data points on a chart. They are screaming alarm bells that demand immediate action. And when those alarms go off, the team moves fast. That could mean strapping on a pelvic binder, because a broken pelvis can cause a staggering amount of internal bleeding. It could mean giving a drug called tranexamic acid, or TXA, which helps the body form clots. And it often involves grabbing a portable ultrasound machine for what's called an EFAST scan, a
a super quick look for hidden bleeding around the major organs. Next up is D for disability. And no, this isn't about long-term disability. It's an immediate, rapid check of the patient's neurological status, basically what's going on with their brain. They use a tool called the Glasgow Coma Scale, or GCS, to check the patient's level of consciousness, and they'll look at their pupils. It gives them a quick snapshot of any potential brain injury. And that brings us to the last step of the primary survey. E for exposure and environment. This is a two-part deal. First, exposure. You can't fix what you can't find, so the patient's clothes are completely removed so the team can see every inch of skin, looking for injuries they might have missed. But then there's environment. A trauma patient can get cold fast, and that's dangerous because cold blood doesn't clot. So they immediately cover them with warm blankets to fight off hypothermia.
So let's take a breath. The primary survey is done. The immediate gonna die in the next 5 minutes threats have been dealt with. But the job is definitely not over. Now that the patient is stabilized, the team can transition to the secondary survey. This is a much more detailed head-to-toe examination to find all the other injuries.
Yeah, think about it. That whole primary survey is about putting out the biggest fires. But what about the smoldering embers? What about the injuries that aren't so obvious? The ones that are lurking deep inside the body? They might not kill you in the next 10 minutes, but if you miss them, they can cause huge problems later on.
And that is exactly where specialized assessments come into play. A perfect example of this is urological trauma. We're talking injuries to the kidneys, the bladder, that kind of thing. These injuries almost never scream for attention right away, but they absolutely need a special game plan to find and manage them once the patient is out of immediate danger.
So drawing from expert guidelines, specialists start thinking through the possibilities. For instance, a direct hit to the flank could mean kidney damage. That big pelvic fracture we talked about earlier, well, that puts the bladder at serious risk. Each type of injury has its own set of clues and requires a different plan to diagnose it properly.
And you know what? The process for finding these hidden injuries is just as systematic as the primary survey. It's like detective work. It starts with a clue, the way the accident happened or something they find on the exam. That suspicion then triggers more advanced imaging, usually a CT scan, to get a clear picture of what's going on inside. And finally, a specialist, like a urologist, is brought in to make the final call on a treatment plan, which could be anything from just watching carefully to heading into surgery.
So, when you step back and look at the whole thing, you see it's not just a bunch of random actions. It's a system. It's a highly structured, carefully prioritized protocol that takes one of the most chaotic situations in all of medicine and brings a sense of order to it. It's about turning chaos into control to save a life.
And really, that XABCDE approach is so much more than just a clever acronym to help doctors remember the steps. It represents a real evolution in how we think about trauma. It's a globally recognized, evidence-based system that turns that initial, terrifying chaos into a repeatable checklist, and it guarantees that the thing most likely to kill the patient is always, always dealt with first.
You know, right now, this system is pretty much the peak of modern trauma care. But here's the thing about medicine. It never ever stands still. With new technologies and a deeper understanding of the human body just around the corner, it really makes you wonder, what's next? What will the trauma checklist of tomorrow look like?